Oh, here we are. So, and I want to talk about hydrogels, collagen hydrogels. And you will see after my presentation, also as the previous presentation, that the future might go away from this typical second generation implant. Now, what I'm talking about is the cartilage repair system, or short CARES. So it's a German and Austrian company. And so the hydrogel is made of collagen type 1 from rat tails. Why from rat tails? So it's not bovine, so you don't have a risk for disease transmission. It's in use since 2003, and there have been over 2,000 procedures, primarily in Germany and German-speaking countries, but also in Asia, performed. And this hydrogel you can use at least at the knee, at all defects on the condyle, patella, tibia, and you will see in the following slides how you can fabricate this. So of course you have to do a biopsy. You do this arthroscopically. Then you need the typical collagen digestion of the biopsy, and then you get a chondrocyte suspension. And this is the main difference. This suspension you mix immediately with the hydrogel, and you can pour it in these 6-well dishes. And a final concentration of the gel of 3 milligram per milliliter. You culture it for 12 days, and the gel is 8 millimeters thick. Why 8 millimeters? Now, normally the cartilage we're talking about is 4 to 5, but this is a hydrogel. And by compressing the gel, it can lose up to 70% of water and adapt exactly to the adjacent cartilage. Now, the two main advantages of this technology compared to the standard technologies, that you have not a cultivation in a monolayer, and then you don't have this dedifferentiation as we have shown previously in 2004. So here you see that the cells immediately, they stay in their round chondrocyte shape. So this is the procedure. You see here a typical defect. We have a special punch to get the damaged cartilage out. Very important is that you have a sharp border to the healthy cartilage, because cells might migrate from this cartilage also into the hydrogel. Then we have another punch which is 1 millimeter wider, and then you have here this hydrogel on this special spoon. And here you see that the hydrogel is very proud. But you come with the back of your forceps and you make a massage, and then you really can bring it here in the defect. And here you see there are actually 2 defects, and it fits very nicely to this cartilage. You might use or might not use fibrin glue. We don't use it. We did it in the first procedures, but actually you don't need it. Now, with this type of gel, you can treat all kinds of defects. You see a condyle, trochlea, the tibia, here cysts on the tibia, but also very severe defects, huge osteochondral defects, patella. This is my favorite picture here, a failed mosaicplasty. And, you know, it's as a second-line treatment for the ACI. It's very easy to fill these 3 defects with a kind of this hydrogel. Now, here's one case, a Russian immigrant to Germany, 31 years. He never had treatment. We see this very rarely, this osteochondritis dissecans on the medial condyle, both sides. Huge guy, 2 meters tall. And here you see the defect, which is big defect. And you have to debride this. And what we use and what we do instead of most of the other surgeons, we don't put bone plugs into the defect, reconstruct this by impaction bone grafting, seal it with fibrin glue, and then put the implant on top. You see that here. This looks red because the bone is underneath it. But again, there might be mesenchymal stem cells going into this hydrogel. And you see here in these both pictures that you have very nice reconstructed the articular surface, even in this big defect. Now this is an MRI I want to show you because most of the people after this have an inflammation in the joint. There is some fluid, you see this here, effusion in the joint after 3 months, which normally goes away after 6 months. And what you also can see here very nicely is the difference here between the hydrogel and the fluid. I mean, this is also mostly fluid. You can actually in the MRI look very nicely and differentiate between the effusion and the hydrogel. So this is in histology, a courtesy from Dr. Schneider from the University of Aachen. You see after 1 year some fibrocartilage. This is the process. We all know that you cannot mimic Mother Nature as long as the patient is pain-free. And here you see an arthroscopic picture of this patient before. Now, we did a multi-center study which we just published, and we included 160 patients, mean follow-up 30.7 months. These are the typical ICS inclusion and exclusion criteria. We looked at a couple of things. I want to make it a little shorter today. I have shown this data already in the last meeting, and I just want to focus on the IKDC score. Here the people which have been enrolled, and very important also, as in the previous talk, almost 82% of these people have had previous surgery. Before the ACI, this 57%, and ACL and meniscus or osteotomy 25%. So most people approaching us are not first surgery, but they're mostly like a second surgery after microfracturing. This is very important because of the outcome of the study. Now, what's the next one? Here we go. So the IKDC score, we saw that also previously for this mostly degenerative cartilage defects, is going up from 42 to 75. We looked every year, actually, and here you see this typical plateau after 12 months. So this is 3, 6, 12 months, and 1 year follow-up up to 5 years. And you see here up to 5 years it stays on this plateau, is not going down, and we are very interested about the next 7 and 8 and 10-year data. So very interesting is also the different diagnoses. People who had an osteochondritis dissecans, they started out with the same AKDC score, ICS score, but they ended up at scores about 80, and the others only 60, 67. So this was the only significant difference we found. Here you see the numbers of the patients. All the other points, let's say the bigger or smaller than 4 square centimeters, or the location, medial, lateral condyle, or trochlea, turned out not to be significant. The overall satisfaction, the doctor said, okay, 88% of the patients do very good. We have very good results. And 80% of the patient itself said, okay, this is a very good, good clinical result. So in summary, these results are comparable with the other matrix-based technologies using membranes or sponges we have on the market. Now, I want to give a little perspectives now. Now we have this gel, and we heard a lot of growth factors, stem cells, and also cell-free one-step procedures. So what could you do with these gels? We heard about bone marrow concentrates. Actually, for this transplant, difficult because it's a gel. You might to do this intraoperatively. The second one is you can use cultured MSCs. The third one is we did some experiments where we were trying to stabilize the matrix more, compress it more to make it more harder. And the fourth one is to come up with a cell-free, stabilized, off-the-shelf product. And the first one, bone marrow concentrate. We know that this in the clinical application, I know data from the United States for non-unions, for trauma, femoral head necrosis, spinal fusion, also for critical limb ischemia. But the problem is also here there's a lack of randomized clinical trials. And we have seen some data for articular cartilage repair, and the process is very easy. You can do that. I don't want to go through the details. Here's one of these machines. You can do it in the OR within 14 or 20 minutes. And you end up with a concentrate of these bone marrow cells, which are not pure mesenchymal stem cells, which are all nucleated cells, also white blood cells. You can concentrate in up to 4 milliliters. And you have seen these animal studies from Lisa. And she has found that compared to the microfracture, there are better results if she uses in the horse this bone marrow concentrates. And there's also a clinical trial, which we have seen also previously, a series of 20 patients, and they also claim that we have an improved AKDC score in these patients. So how is the situation, at least in Germany, for this product? And what we did is, one of our study centers, he sent a trial protocol to the local ethics committee. And in Germany, there's the federal regulatory agencies, the Paul-Ehrlich-Institut. And now the local ethics committee sent it to the Paul-Ehrlich-Institut. And the Paul-Ehrlich-Institut in Germany said, oh, this is not for bone and cartilage repair. This is not something as compared to bone marrow transplantation if you use CD35 positive cells. So we got a letter back which claimed it's not homologous use, there's no physiological function, and it should be claimed as an advanced therapy medicinal product, an ATMP, which means that in Germany, this is not for Switzerland, not for Italy, and not for Austria, but in Germany, we have to go the whole procedure, making animal preclinical data, and then show up in the Paul-Ehrlich-Institut with a clinical phase 1 trial for safety. So here you see what he said in his last sentence. The regulatory might be very difficult. But Germany, they always are very trying to set very high standards. In this case, I think it's actually very stupid. Now, second thing, should we replace them with GMP, expanded mesenchymal stem cell from the bone marrow? They're easy to harvest. You get much higher cell numbers. You have no donor site morbidity. That would be the scenario. Very easy, just replace the chondrocytes by stem cells, put them in the hydrogel, and put them in the patient. So we have done some initial experiments where we put the cells in these hydrogels. We made 3 groups, just serum, one with BMP, one with TGF-beta1, and we waited for 3 weeks. And what we found in the histology was, no, it's not going further. Oh, here we go. Now, we found in the histology that actually in the control group, we had some spontaneous chondrogenic differentiation. TGF-beta and BMP2, BMP2 and TGF-beta, we ended up with chondrocyte-like cells in that hydrogel. But here you see we have a lot of shrinking because of this growth factor where the cells, they grab the matrix. We also have this collagen type 2 immunohistochemistry positive, and the collagen type 10 also positive in these hydrogels. We did not see this in the control group, which we just treated with serum. And we found also some expression of collagen type 2 in the BMP and TGF-beta treated group, which we did not find in the control group. So then we did an animal experiment on the mini pig. On the right side, we did an AST, autologous stem cell transplantation. On the other side, we did an ACT, autologous chondrocyte transplantation from the same animal, in the same animal. So you see here the stem cell collagen gel and the chondrocyte collagen gel. This is a microscopic and a histological view. And here you see this very nice bonding to the intact articular cartilage. This is the repair tissue. This is one for mesenchymal stem cells, and this is one for the chondrocytes. You look at the collagen type 2 staining, and here you see again this nice bonding of the gel to the adjacent cartilage. So with these data, we went to the company. So the company said, you know, Dr. Nutt, this is difficult, you know. We have to go to the Paul-Ehrlich-Institut, and we are not sure whether the cells are genetics stable and all these things. So for a small company, it's very difficult to change a process they have established to the stem cells. So that's why we went never to this product, and we did never replace the chondrocytes by stem cells. Now the next option I told you about to compress the gel, make it more stable, because a couple of the surgeons, they claimed that it's not hard enough. So they developed a machine where they compressed it, and you see here with cells. So the chondrocytes were in that hydrogel, and they survived, and they produced collagen type 2. And from that result, the company said, okay, we might go to an off-the-shelf product. And what is now on the market is the off-the-shelf product, which is compressed, but without cells. And you see here a recent animal study in the mini pig, untreated defect in the trochlea, cell-free hydrogel, and a cell seeded with chondrocytes. And you see here this nice repair tissue. There are some differences between the cell-free and the cell-loaded, especially in the collagen type 2 expression. But you get also a nice repair tissue. So that's why we are now on the market since the beginning of this year with this CARES one-step product, which is off the shelf. It comes in 3 different diameters, 11 millimeters, 22 millimeters, and 34 millimeters. And we just started prospective multicenter study with this gel, which can be exactly identically applied as the cell-laden transplant, and this study actually is limited. The first study is limited to defect sizes up to 4 square centimeters. And we also started another study, monocentric, where we're trying to treat osteochondritis dissecans of the femoral head, which is very rare, cystic formation, as you can see here, or AVN stage 3 after surgical dislocation. And also for these young patients, it might be here after microfracturing or drilling, it might be an option if you do a trimming of the neck anyway or something on the joint, trying to get repaired these defects. Thank you very much.
Thank you very much, Dr. Ulrich. Now, Dr. Steve Below.